So from previous speaker, we know the rationale of the treat and extend, which is better than the PRN. And in my talk, I will talk about how I treat my patients with treat and extend and why I do so. So this is purely personal experience. So nothing to do with Bayer or any company. What we learned from the nAMD natural course, as you can see, these patients from 2012, there's a small CMV happen at the fovea. And in 2 years, it grows rapidly and leak badly. So the vision just decline so fast. So when you're treating the patients, you need to treat the patient in the early stage with intensive injections. And as you can see from the Marina study, it showed that the leakage is reaching the peak after the patient enrolled in 6 months. So that means when they flare up, there's a lot of activity, a lot of leakage. So in general, leakage means the activity of CMV. And also you can see that despite the activity reaching peak at 6 months, but the CMV keep growing. So once the lesion become bigger, the vision just decline. So this can explain why in the natural course of nAMD of all clinical trial show that the vision just decline so fast in the initial phase and reaching 2 years result vision less than 20 to 100. But this is not the end of the story. So all the lesions that eventually become scar, they didn't disappear. So the reason why we need to treat intensively, because we need to treat all the leakage. As you can see, once you treat with anti-VEGF, the leakage decrease and reaching the bottom at year 12. So if you look back the OCT response, it dry very fast. Most of the case can dry by month 6, but activity just keep going. So you need very intensive treatment to decrease the leakage, to control the growth of CMV. So the rationale of anti-VEGF treatment is that if you leave it untreated, eventually you have a very big CMV, but if you treat intensively, you can really control, but not disappear the CMV. So that's the reason why we can save patients' visions. And if eventually they are leaving a scar, the bigger the scar, the poorer the vision you have. So the treatment rationale is treat intensely and continuously to control the growth of CMV, leaving the scar as smaller as you can. That's the reason why we can save patients' vision. And this is not a cancer. This is not endless treatment. So despite we know most of patients can last longer than 2 years, but eventually they will scar down. In the Marina study, 20% of patients just scarring without any treatment. So it can stop by themselves. But with intensive anti-VEGF treatments, you can increase the patients without leakage. That means stop activity of CMV from 20% to 50%. So what we learn from the patients is that this is a chronic disease. And when they started, it's very intensive. So you need to treat them with a very intensive loading injections and continuously to control the growth of CMV. And eventually, every year, 15 to 20% of patients can leave the treatment. So it's not an endless treatment. So you have to let the patient know you have to follow us with the treatment for at least 2 years. And most of the case, it lasts more than 2 years. So the vision keep decline. So don't stop by 2 years. After 2 years, you still need some periodically injections to control the growth of CMV. Otherwise, the vision will decline and lose your vision gain. Unfortunately, most of case are bilateral disease. So more than 50% of patients in the case study, after 2 years, they have the other eyes develop same activity. So it's very important to save every single vision of the patients, because otherwise they will lost their both eye visions and lost their capacity in the daily life. So what's the treatment goal? If you look at all the clinical trials, show that the vision gain after 2 years is about 8 letters of ETDRS. It happened in the Marina Anchor study. It also happened in View 1 and View 2 study. So if you take this picture to the patients, they will have the impression that everyone will recover their vision, but it's wrong. Not everyone have the good results. Across the clinical trial, about 8% of patients, no matter you treat with ranibizumab, aflibercept, or bevacizumab, lost 15 letters. So despite you treat them intensively with monthly injections, 8% of patients still lost 15 letters. So not everyone have the good result. And second thing is that you need to look at the initial visual acuity. There's a ceiling effect. If you have the patient with very good visions, like 20/40 or 0.5 visions, their ceiling effect means there's no room for improvement. So you have to look at baseline visual acuity. That's very important. For those 0.5, very good visual acuity, they cannot have the room for improvement. But if you have a very bad visions, you're starting from 20/200, there's more room for improvement. So 8 letters, that's average. But if you look at baseline visual acuity, that's very important for imply the long-term outcome. So if you look at the patients with 23/20, after improved with 10 letters, they only reach 0.1. So from 0.06 to 0.1, patient barely feel the vision improvement. So no matter the vision is good or poor vision, both show that you can stabilize the vision, but you can barely improve their visual acuity. But very important is that you need to let the patient know what if they don't treat. If they don't treat, you're starting with 2200 0.1 vision, you will lose 10 letters. But if you have a very good vision, like 20/40, you will lose 20 letters. What that means? What that means you're in the Snellen. This is the ETDRS. But if you translate into Snellen, you will see that if you're starting from 20/40, then lost 20 letters, the vision will decline to 0.2. So that's a big decline. So the treatment goal is to save the vision, to maintain the vision you have now, but barely you can really improve in the Snellen chart. And also, if you leave untreated, eventually they will lose their vision in 2 years and keep decline, eventually reaching the vision of 0.05. So that's need to let patient know in beforehand you starting the treatment. Otherwise, you will misconduct patient. Patient will feel that I'm not improving the vision, so I may be a non-responder. But actually, you need to translate all this vision gain in the ETDRS into Snellen. So how we monitor our patients? So far, there's no good biomarker can tell which one will be improved or which one will be a non-responder, losing 15 letters. You have to let the patients starting the treatment, then you know the result. So far, the biomarker for the treatment is look at OCT. OCT is very effective when you look at the treatment response and maintain phase to monitor the patient when you need to restart the treatment. So dry the retina is very important. With the aflibercept, after years of fixed dosing, you can have 80% of patients just dry. But if you look at the OCT, it's very interesting. It can reduce the thickness of retina. It can dry the retina in almost 3 months. But if you look at fluorescein leakage really means that the activity of CMV, it declined to the bottom need whole years. So dry the retina and decrease the thickness of the OCT doesn't mean you stop the activity of CMV. So that's the reason why, despite you dry the retina, you still need very intensive treat to decrease the activity of CMV, because OCT and FA leakage doesn't align with each other. So what's wrong with the PRN? The PRN means when you have activity on the OCT, then you do the treatment. If they are dry, you stop the treatment. But the question is that really aligned? No, it's not at all. If you look at the case study, after 2 years of treatment, the vision just declined, despite they have a very good response at year 1 and maintain in year 2, but decline after year 2 to year 5. But if you look at the OCT, the thickness, if the thickness just maintain quite thin and no fluids from year 1 till year 5. So why? Why the vision just decline after year 2 till year 5? And OCT show there's no activity, and you treat those activity with PRN mode, so maintain quite dry. The main reason of that change is that despite the OCT is dry, the lesion, the CMV keep growing. So lesion can grow even the OCT is dry. So if you look at the activity of the disease, you see the fluid. But fluids, once you see the fluid, means there's a CMV. But once the fluid is gone, doesn't mean CMV already gone. It's still there. It still grows. Despite there's no fluid accumulations, but the CMV keep growing. That's the reason why if you look at those PRN treat, after like Marina Anchor study, after 2 years treatment, they follow the patient in PRN mode and treat those activity with anti-VEGF under PRN mode, but the vision just declined. In 5 years, all the vision gain just back to where you started. And very interesting, if you look at the VIEW study, after 2 years of treatment, you treat with cap PRN. That means you treat them with PRN, but if you don't have any activity in 3 months, you still do the injections. The main reason is to control the CMV growth, despite there's no fluid accumulations on the OCT, so they can have a better visual result. Compared with Marina Anchor, after 2-year result, in 5 years, the vision just dropped to where you started. It's much better. So proactive treatment is very important. Proactive treatment try to catch the timing when the CMV, before they flare up, before they have the fluid accumulation, you give the shot. You hit the CMV to control the activity before they flare up. So proactive treatment is very effective in the long term if you compare with the PRN. So what's the evidence of that? Proactive, is that really better than PRN reactive treatment? In the Luminous study, that's the ranibizumab compare with the PRN versus treat and extend in the real world. What we learned from the Luminous study is that the injection number about in year 1, 2 injection more you need for the treat and extend. But the visual acuity is much better. You gain 8.8 letters compared with PRN only 3.5. So in the real world, year 1 show that treat and extend is better than the PRN in the ranibizumab treatment. And also the difference maintained till year 2 and year 3. So in the long term, if you follow the patients with treat and extend, you have a better chance to control the CMV, not just following the fluid and just dry the retina, but you forgot the CMV, and the CMV keep growing and compromise the long-term vision outcome. And what the trend of the work. Now, in the ASRS survey, nowadays, it shows that more and more people shifting from PRN to treatment extend. And also, the trend is that most physicians starting with 3 injections, 3 loading, then following with treatment extend. It's about 62% of physicians around the world use this treatment model. So how to treat my patients? I starting with loading. There's a lot of argument about loading. If you look at a case study, they don't load. They just do the PRN, but they follow patients monthly. So if you try to do the patients with PRN without loading, you have to monitor those patients with monthly basis. And once in 1 injections, you can drive 20% of the patients. With 2 injections in the VIEW study, you can drive nearly 40%. And with 3 injections, you can drive half of the patients. So the reason why I started loading 3 injections, because most of the patients cannot be dry with 3 injections. And also, this is very important, despite they dry, doesn't mean the FA leakage, doesn't mean the CMV activity already been suppressed. So I personally prefer to do the 3 loading to make sure the retina is dry and also make sure the CMV activity is fully suppressed. And what if you don't dry the retina by month 3? Then if you leave the fluid, in the VIEW study, after 3 months, about 20 to 30% of patients still have fluid. But if you treat them in 2-month model, then you have worse vision compared with continuous with monthly injection. So what I do, how I do my patients is that I treat them with 3 loading. Then if they don't dry, I keep injection till the retina is dry. I don't shift that the treatment model to by month 3 if there still has some fluid. So this is very important because once you leave the fluid up there, the vision can decline and vision can lose. So what if cannot see the patient monthly? If you see them every 2 months, maybe you can leave some fluid in the patient's eye. How about if you cannot do the injections right away? You notice fluid, you schedule them to the injections, but the nurse said that you have to schedule 2 or 3 weeks later. Then you prolong the fluids leaving under the retina that will compromise your vision. So optimal treatments, we have to think about, can you treat the patients right away once the fluids are coming out? Can you detect the fluid immediately when they come out? So you have to treat the patients monthly and also monitor them monthly. So it's very important, don't leave any fluids under the retina. And also the treatment response at the first 3 months is very important. It tells you how the long term will be. So the first 3 months result is a very good indicator to tell the long-term results. So since there's no good biomarker and you just treat them after 3 months, and the result will tell you whether they are good responder or they are non-responder. Pretty much 80% can be predicted by first 3 injections results. And also you need to maintain the retina dry. In the EXCITE study, after 3 loading, and there are 2 arms starting quarterly injections. As you can see that at year 1, then all the retina is dry, despite you treat with monthly injections or quarterly. But the visual results are quite different. As you can see, once you leave some fluid under the retina, eventually, despite the OCT show the similar result, the visual results are very different. So always remember, we treat the patients and monitor them with OCT to look at all the fluid, but don't forget, once the fluid is gone, CNV is still there. You still need to treat those CNV. Don't let them flare up and leak some fluid, then you lost some vision, then you re-injections, and you waste your time, waste patients' vision gain. So how can we treat our patients? Can we treat the patients with treat and extend right away? In the ARIS study, it showed that treat and extend can starting after 3 loading. So the visual results is quite same as that we have if we fix dosing. So aflibercept, if you treat with aflibercept, you can start the treat and extend from month 3 after you 3 loading injections. You have very good results, like you treat with fixed dosing. So you can early starting the treat and extend, customize your treatment based on patient's response. And also you can see that the results are similar after year 1. So you can starting the treat and extend early after 3 monthly loading. Then how about the interval? The interval, do we need to following every 2 weeks extension or shortening? In the ARTEL study, they compare the 2 weeks versus 4 weeks interval. Because if you treat with 4 weeks interval change, that will be easier and earlier to achieve the maximum interval. So do we have the same result if we treat with 4 weeks interval? It shows that at year 1, they have similar results, almost the same. So you don't need to extend your interval based on 2 weeks. Then you can starting your loading 3 monthly injection, then starting your 4 weeks interval extensions or shortening. And as we know that the long-term results are very similar. So I'm very comfortable with 4 weeks interval extension or shortening. Then very interesting is that most of the treat and extend, the longest period is 12 weeks, that's 3 months. But ARTEL, they try to extend, they beyond 3 months. And also you can see that most of the patients, about 57% of patients can even extend beyond 12 weeks. That's quite good. That's very good for most of the patients and reduce a lot of treatment burden. This 1 year result, and also if you look at the 2 years result, it's also the same. So as you can see that the treatment response is quite consistent in year 1 and also year 2. And also if you look at the maximum interval, that's 4 months, 16 weeks. It shows that about 40% of patients can extend to 4 months. So give you some imagination that maybe we can extend further. So at year 2, as you can see, the result can maintain. So you can see that there are very large difference between 2 extremes. You can see that some patients need very constant injections. Some people may need only 4 months injections. And the result is pretty constant in ranibizumab. In the LUCAS study, year 1 result and year 2 result are also very similar. It's a bipolar. I said some people need only longest 12 weeks in the interval injections in the ranibizumab LUCAS study, and also you have similar number need monthly injections, and they're still wet. So some people need very intensive injection, some don't. And this is not a cancer, as we said, that there's a chance you can stop injections. So if you look at the natural course of the MARINA study, show that 20% of patients can dry even without the treatment. So there's a chance to exit the treatment. So after injections, when we can stop? If you look at the study, show that the recurrence rates after 3 months of dry, it showed that 41% of patients can recur at year 1. That's our idea. In the long term, about 80% can recur. So once you have patient extension to 3 months interval, probably not good timing to stop the treatment, because 41% can recur in year 1 and 80% can have recur in the long run. Then how about if you treat the patient have dry retina for 6 months? So this is the treat and extend and stop study. Show that after 6 months of inactive, then you stop the treatment, then you have 30% of recurrence. And among those recur, half of them happen in year 1, but the other half is recur longer than year 1. So that means once you stop, you need to monitor these patients periodically, and you don't know when it will happen, recur. And also, you need to tell the patients, monitor their visions with absolute grid. Once they feel the vision decline, they need to back to the office right away to have the treat. So the biomarker to detect those reactivations is that 1, the vision decline or absolute grid. 2, follow patient with OCT. And you better follow these patients every 3 months. And don't just look at OCT. Look at the fundus also. If you notice any hemorrhage, if you notice any growth of CNV, that means it come back again. So for these patients, once they stop, they still have chance to recur. So once they recur, they need very intensive treatment to starting the treatment again. As you can see, once you restart the injections, the vision can come back. But despite you treat them right away, you still lost about 3 letters. So detect those cases with recurrence is very important. And here is another study show that if they dry for 1 year, then the recurrence is much less, about 13%. So in my office, I just stop the treatment after 6 months to 1 year of inactive, then I think the patient may stop the treatment. So how I treat my patient with treat and extend. I starting the injections and I treat them to dry. Then I extend my treatment interval from monthly to 2 months to make sure they are dry. Then if they are dry, then I shift to 3 months or 4 months. Once I have some patients with fluid, then I shifting back 1 step from 3 months to 2 months, from 4 months to 3 months to monitor the good timing of flare-up or reactivations of those CNV. So treat before they starting to accumulate the fluid of there. And if I don't have the activity after 6 months to 12 months, then I do the frozen angiogram. Once I have the frozen angiogram, there's a leaking, then I restart the injections because frozen angiogram leakage means activity of CNV. Then once I don't have those leakage on frozen angiogram, then I exist. I stop the treatment, but I still follow up these patients every 3 months to catch those recurrence. So this is my way to treat patients. I need to catch those patients when they have vision decline, when they have OCT activity fluid accumulation, when they have hemorrhage or CNV growth on fundus. So in summary, when I treat my patients, AMD patients, I tell them I try to save the vision, not just improve the vision. I try to save the vision from being blind. Also, they need to with us for at least 2 years. For most of the patients, they need intensive treatment from the beginning with loading injection to suppress all the fluid and also those activity, because when they started, they can be very bad in the first 6 months. Then in the long run, we need to do the training extent to maintain the vision gain with less visits. And also with training extent, we can maintain the suppressions of the CMV. And in the ATEL study, show that the extension period can even up to 16 months. So 40% in the ATEL study show that they can extend to 16 weeks. It's very good result. And once they don't have activity for 6 to 12 months, then I can stop the treatment. But I still need to monitor these patients quarterly and also ask them to self-monitor their visual acuity. Once there's a very few cases have recurrence, then we need to restart our treatment to maintain the vision gain, which has been maintained for 2 years. So this is my way to treat my patient. I hope this can helpful for your daily practice. Thank you for your attention.